Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed. Welcome. You're joining us this week for something new. This is a series we're going to call Choose Your Own Adventure. Here's how it works. Today, for the first part, you're with me. I'll present a case, essentially noon report style. I'll pause at times. At that time, you can pause the podcast entirely, giving yourself some time to think. And at the end, I'll ask a question. The question will have a multiple choice type answer. All possibilities are reasonable and things that I considered during this case. The episode will then end, and next week, Andrew will update you with the answer. Let's get started. So this is a 40-year-old man. His past medical history really only notable for hemorrhoids and chronic abdominal pain, which up until this point, people have attributed to chronic constipation. You're seeing him in the first part of this case in clinic for worsening bloating, abdominal cramping, alternating diarrhea and constipation. This has been going on for 3 years and is similar to the chronic constipation noted in his one-liner. It's been worsening in the last few months, though. He notices dry heaves, bloating. He sits in a hot bath, which makes him feel better. He has hemorrhoids at baseline and actually has some hematochezia, which he's had for 5-10 years, which has actually not changed. He's been limiting meals to see if things make things better or make things worse, and he's not noticed that any particular food group is really responsible for these symptoms. He has actually been in the emergency department twice in the last 6 months for basically the same sort of thing, but with a more severe presentation, essentially acute on chronic abdominal pain. Both times, he was found to be constipated. He had, if you look at his labs, basically a borderline ESR at 26 with a normal CRP, his basic lab, CBC, CMP, lactate all negative or within normal limits. CTAP actually was done twice, and both times just showed diverticulosis without diverticulitis, no cholelithiasis, no biliary or pancreatic pathology, no gastric pathology, and moderate stool burden. Both times he was, again, felt to be constipated, treated with Miralax Senna, bisacodyl as needed, and had resolution of his symptoms with a bowel movement in the emergency department. So again, those are the last 2 visits to the ED. He's now coming to you with sort of a less presentation of the same. His vitals are unremarkable. He basically has had no change in his weight. And his exam is unremarkable. He has a normal abdomen, actually not distended, non-tender, normal active bowel sounds, and with the Miralax and Senna he's been taking, he's actually he's had regular bowel movements every day, every other day at most. He has no labs yet, but again, the ED labs a couple months ago were all normal. I'm going to pause here. Ask yourself, what questions would you ask this patient? Anything else you'd want to know, chart review, and then what you'd like to order next. Okay, a few pieces of information and then a question. So the labs are normal, again, CBC, CMP. Lactate is not obtained, of course, because he's in clinic with you. Normal iron panel, ferritin's normal, TSAT 34, which is normal on our assay. Celiac serology was obtained and negative with a normal IgA. So the question for you now is, What do you want to do next? You have 4 options. Again, I'll give you those options. You pause and think. This time, I'll give you the answer because this is a 2-part case. So, option 1, treat for idiopathic constipation, optimize bowel regimen, and consider prucalopride. Number 2 is to pursue an EGD. Number 3 is to test for H. pylori stool antigen. Number 4 is to pursue a gastric emptying study. Okay. Again, all of those answers are reasonable. In this case, the H. pylori stool antigen was positive. He was treated, and his symptoms resolve when you see him in clinic a month later. Okay, so now you're seeing him in the emergency department about a month and a half after that second clinic visit where he was feeling well. He's coming in now with a week of severe abdominal pain, which is postprandial. He was seen 3 days ago, actually, in the emergency department, and then a day ago as well. So he was seen twice in the last 96 hours. X-ray at that time showed stool burden. He was treated with a bowel regimen and dicyclomine. He had resolution of pain, but he's returning now again with the same issue. And at this point, he's not eaten anything in 96 hours because any food at all, he gets severe epigastric abdominal pain. He's having bowel movements. They are normal in appearance, and he's regular, but he says he still feels backed up, is the way he describes it, in his abdomen. He does feel bloated, and again, he has this postprandial pain. It's severe. He describes it as a knot in the upper abdomen. He actually takes his hand and makes a fist sort of right above the belly button. He's really not having much nausea or vomiting, though. It's really just pain. And when he's not eating, he has no pain. He feels well. And if he waits long enough, the pain always goes away. These symptoms are totally different than his prior episodes where he presents and is found to have constipation, in that they're postprandial. Before, it had been just sort of an acute or subacute pain, but diffuse, always kind of constant. But this is just postprandial. It's much more severe. On the emergency department visit yesterday, he then underwent a CT abdomen pelvis with IV contrast, which was notable for a possible enteritis. The stool burden had resolved from prior CTs as well as that X-ray 2 days prior. He was given PPI therapy and asked to follow up closely outpatient with GI. His pain resolved again in the emergency department, though he had been NPO during that period of time. He's now back again, as I said, with the same issue. Basically, he's treated inpatient with an IV PPI. He, again, feels better, and he's hoping to go. You've talked to the GI team. They think it's reasonable to see him outpatient, which had been the plan the prior day. And you begin to advance the diet. He tolerates clears and having, regular bowel movements. And so you find yourself now advancing to a solid diet, discharge later this PM. You're thinking maybe this is gastritis, peptic ulcer disease. GI is going to see him very closely outpatient. They already know him. So seems reasonable. You're called back to the bedside now for a severe recurrence of that abdominal pain. And this is probably the pain he's described, but you yourself have never seen it. So he's writhing around in pain in the bed. This is a guy who an hour prior looked very well. He's a healthy 40-year-old guy. Plays sports, smiling, talking on the phone, was working on a computer. Now he's writhing around in pain, eyes closed. He had eaten breakfast about 45 minutes earlier. It had been toast, eggs, grits, and coffee, he tells you. He's really not able to actually give you much history. He's in so much pain. You obtain labs. Basically, the only thing that's abnormal is a lactate, which is now 3.8. The upper limit of normal is 2. And it had, again, been normal on arrival in the last two presentations as well. His abdominal exam is notable for severe tenderness in the epigastrum. No other quadrants are tender. He has no nausea, just pain. And again, he had a CT abdomen pelvis with IV contrast 2 days ago, which showed, again, possible enteritis, and that was really it. While you're deciding what to do, his pain resolves again entirely. He looks well. A couple hours later, his lactate has resolved. And so the question is, you can't feed this guy. He looks well when he's not eating, but that's the whole reason he's here. So what are you going to do next? You have 5 options. You have more than 5. But for the sake of this exercise, here's 5 things that we thought about. First, it's been 2 days. Repeat the standard CTAP with IV contrast and add PO contrast this time. 2, add Mylanta, calcium carbonate. If no response to that sort of enhanced PUD treatment, we'll do an EGD tomorrow or the next day if GI agrees. Number 3, obtain a CT triple phase of the abdomen pelvis. Number 4, basically pursue a fluoroscopic upper GI series instead of EGD. And number 5 is obtain an MRI, MRA of the abdomen pelvis. So that is where I'll leave you. We will see you next week, where we'll reveal the answer and then discuss how we got there. So once more to repeat, the options are 1, repeat standard CTAP with IV and PO contrast being the new thing. 2, enhance the PUD disease treatment, and if no response, then pursue EGD. Obtain CT triple phase AP, which is the 3rd option. Number 4 is same as number 2, but you're going to pursue a fluoroscopic upper GI series instead of EGD. And then the last is number 5, MRI, MRA of the abdomen pelvis. Best of luck, and we'll see you next week. This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us at dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.